So, hello, my name's Dr. Simmonett. I'm a paediatrician up at Blackpool Hospital. And really, we're talking about solutions and a different way of working, accepting the fact that even if we do improve our workforce, we're still going to have gaps no matter what we do. As a trainee, I don't think I worked on any rota that didn't have a gap on. So it's looking at other ways of working. So at Blackpool Hospital, we received some physician associate students, and we were very, very impressed with them all. So to start with, I'd just like to introduce Natalie. She's our current physician's associate, and we hope she's going to stay with us. And I'm just going to let her talk about the training she's had and her background, and then I'll talk about what we've been doing within Blackpool with Natalie.
I need to stand here. Hello everyone, my name's Natalie. So I've been working on paediatrics at Blackpool now since March, but just very quickly what my background is. So I did my undergraduate in medical science and I did a master's in clinical neuroscience. And after oohing and ahhing what I wanted to do career-wise, the opportunity of physician associates came up, and UCLan advertised quite widely actually to a lot of science graduates. So I picked up their email and applied for physician associate studies at their university. So this involved 2 years of clinical training. So they used the background of our science degree to say that we had our core anatomy, physiology, pathophysiology knowledge, and it was then enhancing that into a clinical perspective. The first year was mainly around general adult medicine, and involved a series of lectures, 50% of our time at the university, 50% of our time in the hospital, rotating around different areas of general medicine. And in the second year, going over more specialities, so paediatrics, obs and gynae, psychiatry, surgery, and a bit of time in A&E as well. So, like I said, 50% was in clinical placements, where a lot of our attention was on completing DOPS, CBDs, clinical reflections, very similar to the medical trainees, what they do on their placements. And combined with that, completing assignments, and we did written examinations and OSCEs back in university. And once we completed completed the course in the 2 years, we were then put forward to sit the national examination, and that involved a written exam, questions covering all of the 2 years of training that we've done, and then a national OSCE of, again, all the different specialities that we did. And so when we qualify, we work for 5 years, and then we've got to revalidate, and we have to sit the national exam again. And that's how it goes for us.
So in March, we were given the opportunity within paediatrics to take on a PA, and we thought we'd try it. So somehow, I'm not quite sure how this happened, but I got, for want of a better word, dumped with finding a role for Natalie within our department, which was quite interesting, and it's been a learning curve for us both. So just in the background, so basically we need to know what a physician associate could do. So this is taken from their website. So the idea is they take medical histories from patients, they can perform physical examinations, diagnosis, chronic illnesses, performing diagnostics and therapeutic procedures, analysing tests, promoting healthcare. So most of them were in adult medicine already, so they've been established for about 3 years in adult medicine. There are some in general practice. I don't know if anyone here's got any PAs within general practice, and emergency medicine. So they were around and they were established. I contacted the faculty of physicians associates and asked them for anywhere that had paediatric in their teams already. They gave me 5 hospitals, and I can't remember them all now. One was Leeds General, which trying to find out where in Leeds General they were working was very difficult, and I never managed to. One was Kirk, who have them working on their SHO rota. There was 2 very far down south in Cornwall, both of which I phoned and said, no, I don't have any PAs in paediatrics. We don't know where they've got that from. So, and Natalie's recently been to their conference, and she is the only one. Good, right. So we're back to square one of working out what Natalie could do for us. The problems we've had, so initially our plan was to get Natalie onto the reg rota. The problems we've had was sort of looking at what she can do and cannot do. And at present, unfortunately, the PAs cannot prescribe, which is a massive problem. It should be sorted, we hope, by end of next year, we reckon? 2020. Yeah. So it should be sorted by 2020. But it is a massive issue when you've got someone working within your department who can't prescribe, who really can prescribe in terms of their knowledge base. The other important things is there's no formal structure, so no formal monitoring. So unlike us who has GMC or the nurses that have the NMC, isn't it, NLC, they don't have to join a registry body. And that's been a major issue for things like getting Natalie to do the APLS or NLS. They won't accept her unless she's got a registered body. So that's been very difficult. It's been a few discussions, and a lot of them we've got through because they do have something they can voluntarily register with. They do have to meet these national standards of training, so we do know that they are trained to a certain standard. So they don't have to join. So with risk of repeating some of what Emily's just presented, we have massive rota gaps. So these are the same figures as I think Emily presented to you. So vacancy rate is most higher on the higher level, so registrar level of training. As I said before, I don't think I've ever worked on a rota that's got full training, and it puts a lot of pressure on everything else. And as you said, every single specialty and healthcare within the NHS has the same problems. So a lot of the plans to start with was to get Natalie trained up within about 3 years to get her on our reg rota and not take the place, but help with the rota gaps. We have some experience in using other trainees other than doctors. So we've got advanced nurse practitioners and neonatal practitioners who on some places do act on the medical rota, and they work extremely well. We do know that there's PAs in high dependency setting which works really well. So they do a lot of the things like lines, lots of blood tests, a lot of chasing things, and general day-to-day care of the patients. And actually in A&E, again, it works very well. But because we've not managed to find anywhere else in the country that has a Natalie, all eyes are really on us to watch where we go with it. So what we've done, so they literally give you nothing. So we start with a PA and there's no, you need to get this done, you need to get that done, she needs to have training in this. It's literally you do whatever you would like with this person. They can do whatever they want. So the rules are, there are no rules. We make them up. We have to, as long as we are looking after her and making sure things are safe for her, there's no limit to what they can do other than prescribing or ordering x-rays. So we felt as a team that we need to prove that we are training her for both our point of view and also because Natalie needs some evidence that she's experienced, and if anything happened, she needs to have that sort of backup that she's had some training and things. So we designed a portfolio system which is based very much on the doctor's portfolio. So they do things like, she does case-based discussions with people, so talking through the cases. She gets examinations and watched doing examinations and has had those forms filled in. We've given her a certain number of procedures to do before performing them alone, and Natalie's excelled at all of them. So you're doing cannulas, you're doing blood taking, trying with LPs. We've successfully done LPs, we've successfully done LPs. And we have been reviewing the situation as we go, making sure that her training is up to standards. She has an agreement with us, which is very similar. Then everyone starts with a contract of what she expects from us in terms of training, and actually what we expect from her back again. So we've had a few problems along the way. As I said, we've had problems getting Natalie onto NLS and APLS courses, mainly because of this lack of registration. We're hopefully past most of those in that we can do in-house a lot of the time. But it's been an issue that needs addressing, really, and we're trying to feed that back down to the faculty of PAs. So having Natalie work for us over the last 6-7 months, we've made some changes to the way we think. So instead of trying to get someone to replace a doctor, we're actually looking more at changing the way we work, which makes more logical sense and probably better use of Natalie's time. So one of the things Natalie's been doing that's been amazing, and she's been doing really well, is looking at the Looked After Children Clinic, because in Blackpool we've got a big problem with the Looked After Children's Clinic in that we're well behind what... So for those of you who don't know, the Looked After Children's Clinic is for those who are in care. They should be seen by a doctor and assessed whether there's any need. And a lot of it is paperwork, and you need to be very thorough with it. So we were very behind, and Natalie has revolutionised it, and you wouldn't believe that it's now on computer, which has made such a huge difference. And she's taken the time to fill in the forms before a doctor actually sees them. And that's freed up the amount that a consultant needs to be sat there doing this sort of paperwork type thing and seeing the patients. And our ideal scenario is that Natalie is trained. She can look at these children as well. Our only sticking point with that, again, is someone recognising that Natalie can do that. So at the moment, the council feel it should be a nurse or a doctor, but it's because the PAs are not recognised so widely. So it's another little bit of an argument. The other things we were looking at is, again, changing the way we work. So allergy clinics, Natalie is amazing at taking really thorough histories, and things like allergy clinics are the perfect place for this. So a lot of it is history-based, so you need someone who can take the time and do that, and actually having Natalie to do that sort of work then frees up someone else to be doing other work. So I think for us, employing Natalie has been really good for us, and I think rather than looking at replacing doctors, it's looking at changing the way we work. I would be very grateful for any suggestions if you've got for what perhaps skills PAs could do within the workforce.
Hi, thank you very much for that talk. My name's Kim Williams. I'm a nurse consultant in paediatric emergency. I'm working at Lancashire Teaching Hospitals at the moment. I teach on the APMP course, which is based in John Moores. I also work in Ormskirk Hospital. So I think, did you suggest that the PA there works on the SHO rota? He doesn't.
Oh, there you go.
He supports the rota, so he very definitely does not work on the rota. I'm really, really interested in the PA role, because I think it does highlight for us. We have new roles. We have ACPs, advanced nurses, advanced physios, and we also have physician's assistants now. And I think it gives us an opportunity to think about, when we are talking about rota gaps, I think what we have to think about is what are the skills within your service that you're looking to fill, rather than filling a rota. And it does always worry me when people talk about filling rota gaps. I think Natalie obviously has significant abilities that will fit into a lot of the roles, and I think you came up with 2 roles at the end which I thought were perfect, because actually there are restrictions to what Natalie's going to be able to do, and I think perhaps the role that PAs are going to fill is they're not decision makers per se. They're not going to be your clinical leaders of the future, whereby your ACPs are people where they're invested in not just clinical skills, there is leadership, research and education within their roles. So I don't think I can help you with any thoughts of how it might fill, but I think you're thinking about more protocol-driven things which are safe, because we have to be clear that the people who are doing those roles are actually safe to do them.
I think you're absolutely right. I think, and talking about protocol-driven isn't an offence to any of the PAs, because their background is very science-based and they will be able to do them, but actually without any protection there as well, protocol-driven base is where we need to go, I think, with their employment. Love to have a chat later about your experience as well.
Hi, I'm Katie Walsh and I'm the infant feeding coordinator for Lancashire Community, and I'm just, I suppose I'm interested in perhaps if there is a wondering perhaps why our health visiting workforce might refer in paediatricians. Hello? Just hold it a bit closer. And I wonder if there's a role there for us to have those clinical discussions around, you know, maybe some of the challenges we face for feeding for the first year of life and breastfeeding and weight gain, and whether that's a role Natalie could play.
Yeah, I think one of the things I've not touched upon on here, which we do have to consider in these things, is things like pay. And Natalie will be on the payroll to band 7 to 8. So it's whether or not we're making the most of her training, her background. I'm very keen. I like the idea of the sort of well baby clinics that we used to have prior to sort of cutting back on services. And that is something that maybe Natalie would be extremely good at.
Maybe not necessarily for well babies that are thriving and that are managed within our health visiting service, but maybe those babies who we have concerns about, who we may want to have a conversation with a paediatrician, or, you know, prior to a referral, you know, to consider if that can continue to stay within our service.
Absolutely, sounds like a really good idea, yeah.
Hi. Previously, I've worked for East Lancashire Hospitals, supporting paediatricians there in terms of developing the roles. And I just wanted to bring it back to that sort of what can we do together as a system to support. So I just wanted to link you in with Dr. Umidi and Dr. Sibley at East Lancs, who were heavily involved in the curriculum for Year 2 at UCLan, and also had some early discussions about developing a role. They haven't got one yet, but we're going on that journey. And in doing so, I was previously involved, and we spoke to a PA down in London, a lady called Alex Gillingham, and I've still got Alex's contact details if you want that. She spent quite a bit of time with us. I got her from the census that you'd looked at. She spent quite a bit of time with us talking about her role, which, as you rightly say, was in high dependency within paediatrics. But she's more than happy to get involved and help out in terms of developing the role further.
Yeah. I think it's definitely worked in high dependency, and it seems to lend itself extremely well to acute situations. I think if anyone does in the region, and obviously AMSCOT we need to sort of link in with, I think it would be very useful to keep talking to each other, because there might be some, I like to say, good ideas other people have, or experience that we've had that we can get around these things like the APLS and those sort of things.
Anybody knows how many physician associates are there with UCLan right now? Just a question, I'm just wondering.
In the country?
With you saying UCLan is running a scheme of physician associates. How many currently, we've seen one, but I'm just wondering how many there are. Because there was a flying one in my hospital one day when I was doing ward round, never saw him again. So I just...
So in UCLan, when I was training, there were 22 of us, but there are some in Manchester and Liverpool in the northwest, 35 each in each of those. And then the next cohort, it increased to 30. And then I believe the ones that came in February, I think it's about 30, 35. But they're now running an undergraduate PA course as well, which is a four-year course. But I think that's up and running from September, so I don't know what the numbers are for that.
I'll give it back to you. It's basically for a question for Natalie as well. Again, as I said, in Cumbria, the North Cumbria have already taught 25 PA associates in their pediatric training and teaching. There is a second batch which is starting in February, and there are again 25 students which they are expecting. But again, from the value for money, it is important to get the right role and right tailored role so that it fits the gaps also, but works for you. I just wondered what was promised or what was your vision when you wanted to join Physician Associates to help or join NHS? What was your vision then?
I think what highlighted it for me was just the opportunities. I think the idea for me that there was no sort of set role, there was no sort of you will be doing this, you will be doing that, and it came apparent that it would be sort of like a two-way street, that we would develop the role together, and I quite liked that I'd be able to put my input in as well as get an input back to me, and that my job would then be sort of a joint decision as opposed to just being told what to do.
Co-designing, which is thank you.
I think it was really helpful to hear what's possible, and I think it's one of our first talks on different roles within the medical teams, and I think we all have multi-professional bodies, and we need to look at how we best use them. So it's really helpful. Thank you very much for this first talk.